Welcome to the conference on opioids and pain in the elderly. My name is Wanda Hisberg. I am a doctor specialized in geriatric medicine and palliative care. I'm pleased to present Dr. Sebastiano Mercadante. He's an adjunct professor of palliative medicine at the Anderson University of Texas, Houston, the director of anesthesia and intensive care unit at the main regional center for pain relief and palliative supportive care unit of La Maddalena, Palermo, Italy, and has received the John Mendelssohn MD Award for extraordinary contribution in palliative care. He is the scientific director of the Regional Home Care Program at Samot on the Sicilian region and has received the Award of Excellence in Scientific Research by the American Academy of Hospice and Palliative Medicine. He has published multiple articles, chapters, and is considered a reference on the topic of opioids worldwide. Thank you for joining us. It's an honor to have such a distinguished guest today.
Ladies and gentlemen, thank you very much for inviting me to the World Congress of Gerontology and Geriatrics. Unfortunately, my presentation is by web. My topic is opioids and pain in the elderly. This is my agenda. I will talk about the opioid therapy for older patients. There's difference with adults, symptomatic treatment. Again, there's some difference with adults and the cognitive function. Any difference with adults? Some time ago, I wrote this article regarding the pharmacological management of cancer pain in the elderly. And of course, opioids still remain the cornerstone of cancer pain. And again, we know that older patients may have some problems in terms of metabolism and probably also in terms of comorbidity because of the interaction among the different drugs that normally are commonly used in patients with pain. So we need to consider the pharmacokinetic and organ dysfunction typically present in the elderly. And again, what is the capacity of older patients to tolerate opioid therapy in terms of adverse effects? I will follow a pathway according to my research agenda in this year. And the first paper I want to show you is the pain is based on the pain characteristics and analgesic treatment in aged adults. It is a retrospective analysis of 4 weeks in advanced cancer patient followed at home. This comparison with adults was based on assessment of pain intensity, pain mechanism, presence of breakthrough pain, analgesic treatment in the last 4 weeks of life. And then we divided it in different groups, adults and older. But among the older patients, we divided in 3 subgroups that were considered to be old, older, and oldest. We observed that no difference was reported in pain intensity among these groups of patients, but the very old patient presented a lower prevalence of breakthrough pain, probably due to a less activity. And significant change in opioid doses were reported with an inverse relationship with age. And again, opioid switching was less frequent in older patients. So we can say that opioids can be used effectively in older patients, that low doses of opioids produce a good analgesia with a reduced need for opioid switching, compared with adults, and the prevalence of breakthrough pain was shown to be lower in the oldest group. In another papers, we analyzed the factor influencing the opioid responses, particularly with age and gender. Other patients received again less oncological treatment and lower opioid doses, but similar adverse effects and similar pain relief. So we can obtain a good analgesia with limited adverse effects with lower doses of opioids. So all the patients are responsive to opioid treatment. The only things that we are analyzing in the next slide is that increasing age is associated with cognitive impairment and myoclonus. However, we have to underline the reduced capacity to report pain, typically in older patients. So we need absolutely to assess this kind of patient regardless of their spontaneous reporting. Any opioids should be individually titrated against the facts, despite the different wide inter-individual variability, exactly like in adults. That can be ascribed to different factors, including the pain syndromes, some patient-related factors, and one of these component is, of course, age. So the selection of the initial doses should be guided by patient age, but subsequent doses must be titrated according to its effect. And specific drugs, this methadone, that is frequently used in Argentina because of the low costs, but is difficult to use. In this study, we included the patient treated with methadone and followed at home, and the very old patient received again lower, but not significant lowest dose of methadone in comparison with adults while reporting similar pain ratings. So we can use also difficult drugs like methadone that is characterized by a long half-life elimination and tending also to accumulation. What is important is the experience, the capacity to use these drugs. What about the monitoring of opioid therapy? This is a very old study published in 1997, for example. Again, advanced age was characterized by a lower and slower opioid escalation index. That means that in older patients, we need just a small increasing time to achieve a good analgesia. What about the opioid escalation? In patients who are receiving already opioids and requiring a further refinement of opioid therapy, there is a difference with adults. Again, the answer is not. In any case, opioid doses admissions that are lower in older patients, but no difference were found in routes, need to switch, opioid escalation, and other parameters in comparison with younger people. This data contradict the assumption that older patients who already receive opioids are more susceptible than younger adults to opioid adverse effect during opioid titration. So during titration, we have to be careful exactly as it occurs with adult populations. What about the role of the age in studies of breakthrough pain medication? Again, not many studies have been performed, but in general, we can say that no difference in terms of dosages, especially when using those proportional to the background analgesic drugs. This is an example of intravenous morphine used for breakthrough pain. No difference in age, gender, pain mechanism, and time of adverse events were found. That means that we can use softly intravenous morphine to titrating the dose in patients with cancer patients. And in fact, we tried that at the same doses, more analgesia without more adverse effect. That means that the proportional doses of opioids used for breakthrough pain provide a good analgesia with less adverse effects and no difference in terms of intensity and the frequency of adverse effect. So again, we can use breakthrough pain medication similarly to adults. And these and other studies that proved again that age, gender were independently associated with dosage of some fentanyl products. That means that you can use drugs, for example, fentanyl product, nasal or transmucosal oral fentanyl with a lower dose but similar efficacy. And this is a big studies performed in Italy in 32 centers. It actually is the biggest study of breakthrough pain, particularly giving relevant information regarding the characteristics of breakthrough pain and the factors influencing the clinical presentation. For example, older patient had a lower number of breakthrough pain episodes as reported before, and some variables independently associated with long duration, including age, for example. And again, age was associated with the interference with daily activity, other than other factors that we examined in these studies. And again, the effect of age was assessed in this systematic review regarding the opioid switching to methadone. At the present time, age has not been found to be independently associated with dose ratio to be used when switching from one opioid to methadone. The other question was, are older patients responding differently to symptomatic treatment? Because when we use opioids, especially in patients with cancer, they have some symptoms that may be related to adverse effects. There are some difference. Okay, this is one paper we published some years ago in which we wanted to assess the pattern of symptoms and symptomatic treatments in the difference with adults in patients with cancer that followed at home. Again, pain control was optimal in all the categories of the age, as you can see, and also the responses was good. Difference in drugs? No, absolutely. More or less, adjuvants were used in similar way in adult and old, very old, and the very oldest and oldest population. But the burden of symptoms worsened in all the groups, but did not differ among the age subgroup. That means that older patients have a similar pattern in terms of burden of symptoms or adverse effects associated to opioids. No difference in terms of use of so-called co-analgesic drugs or symptomatic treatment. What happened in the last week of life? Older patients have problems similar again to adult patients the last week of life, unless for some symptoms. Older patients, again, had a lower opioid consumption and a more frequent use of subcut route and a lower need for palliative sedation. That means that older patient seems to be more protected against the terminal phase of disease, requiring less requirement of palliative sedation at the end of life. And again, these are the differences in terms of pain intensity, number of patients with a numerical scale equal or more than 4. As you can see, no difference with the other population. And again, these are the data regarding value recorded 1 week before, 3 days before, and 1 day before dying. So the difference are limited between adult and older patients. And again, what was evident was the dosages of oral morphine equivalent that were lower in all patients in comparison with adult patients. So to conclude, all the patients have pain similar to that of adults. All the patients responded to opioid analgesics. All the patients need lower doses of opioids, and all the patients report a pattern of adverse effect. And finally, all the patients require less frequently opioid switching, and I could add also less palliative sedation at the end of life. What about the third element that we wanted to assess during this lecture? What about the cognitive function and symptom expression in older cancer patients? This is a study assessing delirium measured by Memorial Delirium Assessment Scale in patients who were admitted in acute palliative care unit. This is the flow chart, so you can see that some patients were had delirium, medium delirium, with a MDAS value of in the range of 7-12, and frank delirium with a MDAS superior to 30 score. And look at the changes after comprehensive palliative care treatment. That means more patients improved their level of cognitive disturbances because patients with the level of medium delirium and frank delirium reduced in terms of number after 1 week of comprehensive palliative care treatment. But one thing to observe that, again, no differences in terms of age between MDAS at medium level and a higher level, that means frankly delirious. Factors associated with MDAS 13 were age, for example, and other factors, including, of course, Karnofsky status. So age is more frequently to be observed in patients having a frank delirium with a score of MDAS of 13 or more. What is the symptom expression in this patient with delirium or not? And again, at 0, at admission, we have this number of patients with delirium and no delirium. As you can see, there is some differences, and there were some difference also after 7 days of comprehensive treatment, especially for well-being sensation. In patients occurs again factors associated with the cognitive dysfunction, including, for example, score of MDAS more than 30, where again age, confirming data that we recorded in the previous paper. Patients with delirium are likely to be older, to have a lower Karnofsky level, and to be home care patient. That means having also probably less survival time. In conclusion, all the patients should be carefully assessed for pain and opioid-related adverse effect and cognitive function. When properly assessed and treated, all patients have similar response to analgesic drugs with lower doses. And age should not deter physicians to treat adequately this class of patients with opioids, which remain the cornerstone of cancer pain management. So thank you very much for attention. I hope to see you again in Argentina, where I have a lot of friends. Thank you very much.
As always, it's a pleasure to listen to you, Professor Mercadante. Thank you. And thank you to all who join us. Thank you.